Hi, welcome to today's Ask the Experts with NOCC. As we near the end of Ovarian Cancer Awareness Month, we want to go back to the basics with an Ovarian Cancer 101, so to speak. Before I introduce our expert, Dr. Sharon Lewin, I wanted to remind you that we welcome you to use the chat to let us know where you're coming from. We will have time at the end for questions, so feel free to type those in as well. But please remember to keep those questions general because we won't be answering any specific medical questions. Now I would like to introduce our speaker for today, Dr. Sharon Lewin. She is a longtime advocate for women and women's health and has more than 19 years of medical research and community outreach experience. She is board certified. She is a board certified gynecologic oncologist who serves as the medical director of the New Jersey-based Holy Name Medical Center's Gynecologic Oncology Division. She is an assistant clinical professor of obstetrics and gynecology in the Icahn School of Medicine, Mount Sinai Hospital in New York. She is also the founder and executive director of the Lewin Fund, responsible for the organization's operations and for setting its strategic vision. She is their chief ambassador, responsible for advancing their mission to invest in grassroots initiatives and research that directly support women afflicted with cancer and their families. And she is also a member of NOCC's Medical and Scientific Advisory Board. Welcome, Dr. Lewin.
Thank you so much for having me here today.
Thank you so much for carving out just a bit of your time for us. Let's just jump right in and get started. So maybe you can share with our audience today, what is ovarian cancer?
So ovarian cancer is a cancer that either starts from the ovaries in a woman or even the fallopian tubes. We actually know now that a lot of ovarian cancers actually started in the very end of the fallopian tube. Thankfully, these are not very common cancers, but very important to talk about.
Do you want to share a little bit about there's maybe some different types of ovarian cancer? Because I think, and I know we always go straight to a certain kind, the most popular, which is high-grade serous, but maybe you can explain a little bit about where they come from, the cells, and a little bit about the different types.
Absolutely. So there are many different cell types of ovarian cancer. As you mentioned, a lot of the most common type is what's called epithelial ovarian cancer, which starts from the epithelium or the cell lining of the ovary. There's another type that's called a sex cord stromal tumor or germ cell tumor, and that arises from a different part of the ovary. So these cancers are treated differently. The epithelial ovarian cancers, for example, most commonly happen in older women. Some of the germ cell or stromal tumors can happen in younger women, but there are different cell types based on the origin from where they occur in the ovary.
Clears it up because I know, I didn't realize when I thought ovarian cancer, when I was first diagnosed myself, I thought it was one and the same, but there are many different types.
It's true.
Maybe we can talk a little bit about the symptoms. So for those who are not ovarian cancer survivors, but are tuning in just to learn more, what are the symptoms that someone should be looking for?
So great question. Ovarian cancer used to be known as the silent killer, but we now know that it's really not so silent. And we see in a lot of literature all across the globe that women really don't know the signs and symptoms of ovarian cancer. And they actually, sort of looking back, had symptoms for many months, sometimes 6 or 8 months or longer before they've had a diagnosis. That's why it's so important to talk about the signs and symptoms, which are actually sort of a little bit vague in some ways. So it's things like abdominal or pelvic pain, feeling full too quickly, bloating, any pain on urination, difficulty eating. Now, some of these things, like I mentioned, are vague and can happen with other non-cancerous things. But if a woman is experiencing these on a repetitive basis, she really needs to see her doctor right away and definitely have imaging.
When you say see her doctor, does that mean see her primary, see her GYN? Who would you recommend she start with?
Great question. I mean, either one, the primary or the GYN, but I definitely would advocate seeing a gynecologist. Sometimes we see women are sent to a GI doctor. They're sent to a lot of other doctors before they actually end up with a gynecologist or a GYN oncologist. A lot of women too, after they have children, stop going to their gynecologist. And it's really important that women see their gynecologist every year, regardless of their age. But I would say if you have any new symptoms in your belly, bloating, pain, all those symptoms I mentioned, definitely see your gynecologist right away. And you really need to advocate that you have imaging. That's very important.
For the imaging, and maybe you can talk a little bit about what kind of imaging would you suggest?
Well, if a woman came to me with those type of symptoms that I mentioned, I would definitely want to move straight to a CAT scan. That's really the best way to look at the whole pelvis and the belly. You know, unfortunately, we don't have a good screening mechanism for ovarian cancer. I wish we did. So much research going on to try to find a way to catch these cancers in earlier stages. That's why for women who we know have a high risk for ovarian cancer, like those with a BRCA or BRC mutation or another high-risk gene, when a woman is done having children, we recommend removing the tubes and ovaries since we don't have an effective screening mechanism. But really know your body, and any new symptom definitely needs to be worked up, as long if it's persistent and repetitive, I should say.
Right. You touched on a couple of the questions I have a little bit, and I want to kind of dig a little bit deeper. So risk factors, you know, you talked a little bit about the BRCA mutation. So having a genetic component is a potential risk, but what about what other risk factors are there?
So the hereditary component is very important. I'm a big proponent of genetic testing, really knowing your personal and family history, talking to your gynecologist, your primary care doctor about them, and see if you meet the national criteria for genetic testing. Like the data says, 1 in 4 women who go to an OBGYN office now meets criteria for testing. So it's really a lot of women. If you have any family history of ovarian cancer, breast cancer at a young age, for example, several family members with breast cancer, colon or uterine cancer, particularly at younger ages, you know, definitely talk to your doctor. And now we have actually metastatic pancreas cancer and prostate cancer. So the criteria has really expanded, and it's important to talk to your doctor every year. You know, the genetics is a key component. We really don't want to miss any of those hereditary cancers. Another big risk factor is actually being overweight. Obesity is actually a cause of about 13 different kinds of cancers now in the United States, and ovarian cancer is one of them. So certainly, by eating healthy and staying in ideal body weight, that's one thing you can do to prevent ovarian cancer as well as other cancers. And then some of these things are much smaller risk factors. For example, never having been pregnant, never having breastfed, but those are much, much smaller. I think the bigger components are the genetic piece and the obesity piece.
And age, right?
Age.
Right. For most of the ovarian cancers, or most ovarian cancer is diagnosed post-menopausal.
That's
not
correct.
Other subtypes, but
that's exactly right. That's exactly right.
So what could someone do? And you touched upon this when you talked about, you know, either tying tubes or moving tubes and ovaries. What kind of things could someone do to reduce risk? Obviously, losing weight, if being overweight is a risk factor. Any other suggestions?
Yes, definitely. So absolutely staying in an ideal body weight. And you can calculate that by Googling what your BMI is, or your body mass index. And that's where you put in your height and your weight, and it'll tell you on a calendar or a little schedule what category you fall into. So being in the normal weight category is very important. Also, birth control pills are very protective against ovarian cancer for any woman in the general population. 5 years of ever use, according to some studies, reduces the risk by about 60%, and 10-year use by about 80%. So birth control pills are very protective. Also, of course, knowing your family history, undergoing genetic testing if you meet criteria, and then things like, you know, having a pregnancy, breastfeeding, those type of things definitely also reduce your risk as well.
Great. One myth that we are always trying to make sure people understand is that when you do go see your GYN for that annual exam, the path does not test for ovarian cancer. It's great, right, at detecting cervical cancer, but not ovarian. So can you speak a little bit about the lack of screening that we have and why that is? Why is there no screening for ovarian cancer?
Well, it's not a very common cancer. There are only about 22,000 women every year, but it is unfortunately diagnosed at very late stages because we don't have a good screening mechanism. Although we do know in data that a lot of these cancers are festering for at least 5 years before we detect them clinically. So the ovaries are small and they're basically free floating in the peritoneal cavity, which makes them difficult to screen. Like mammograms, colonoscopies, much more effective screening mechanisms. So, if someone has a BRCA mutation and she's young and wants to keep her ovaries, we do transvaginal ultrasounds and CA-125s. That's a blood test to detect the tumor marker, but they're not that sensitive. And we really only do those until she's ready to remove her tubes and ovaries.
How would someone get diagnosed? What kind of tests or surgery or biopsies are needed if ovarian is suspected?
What often happens is when a woman has those symptoms that we've mentioned, she'll then undergo imaging with a CAT scan. And then often we'll see findings that prompt a referral to a GYN oncologist. So it's actually very important to see a GYN oncologist. Outcomes for women with ovarian cancer are definitely better. We see in the literature if someone is treated by a GYN oncologist. So often we see things on a CAT scan that are suspicious. That blood marker for a CA-125 usually is markedly elevated. And if a woman is a good candidate, we usually try to have surgery first, because the best outcomes and the best data for women with ovarian cancer are to have surgery first and remove all of the disease. So at that time, we usually send a biopsy during the surgery to really confirm the diagnosis. Now, if someone isn't a candidate for surgery for whatever the reason may be, and we can talk about what those are, sometimes she may have a percutaneous biopsy, and then we start chemotherapy first.
Do you want to elaborate on what you were just saying about a candidate?
These can often be pretty big surgeries with potential risks. And so we have to be sure someone is hardy enough to undergo that surgery. So someone, for example, who might be too old or frail, it would be better to reduce the disease burden first with chemotherapy. Or sometimes on the CAT scan, we see areas that are very difficult to remove. And the goal of the surgery is really to remove all of the disease. So those are some of the factors that go into place when we're trying to decide surgery first or chemotherapy first.
Can you talk a little bit more about how it's treated once you are diagnosed with ovarian cancer?
Really, the best outcomes are for surgery, as I mentioned, to remove all visible areas of disease. And when a woman has recovered from that surgery, then she's treated with chemotherapy. So really, and this is epithelial ovarian cancer that I'm talking about. I should say that, and that's the most common kind that we take care of. Because sometimes there are some germ cell tumors, for example, that are caught at very early stages and they may not need additional chemotherapy. So we're just talking really about the epithelial kind, which is the most common. Now, there's been a lot of data that has really changed the standard of care for newly diagnosed women with ovarian cancer. So it's really important all these women have genetic testing right when they're diagnosed to see if she has a BRCA mutation or not. If that germline genetic testing is normal, that's what's inherited from the parents, we need to reflex to do tumor testing to see if there's a BRCA mutation in the tumor itself. That's something that's acquired, not something that's inherited from parents, or also to see if there's a phenomenon called HRD or homologous recombination. And the reason that I bring that up is because that helps guide our decisions for maintenance treatment now, which has really changed since the FDA approval of certain Parp inhibitors in the spring of 2020. So, that's how most women are treated: surgery, chemotherapy, a combination of those, and then often followed by maintenance with a Parp inhibitor.
How about, can you talk a little bit about survival for ovarian cancer? I know things have changed in recent years with the introduction of the Parp, but maybe you can just tell us a little bit.
So women are definitely living much longer now with ovarian cancer than ever before. And so I try to be very hopeful with my patients because it's very important to know that, I can talk to you about the average numbers, but I think we're actually doing better than that now in light of the Parps and really quality surgery. And so often too that we don't have a way when we first meet patients and take care of them to sort of see how they're going to do in time. And I have a lot of women who had stage 3 or 4 ovarian cancer and after their initial treatment have been in remission for many years. And so, yeah, exactly. And so I try to encourage my patients definitely to be educated and advocate for themselves, but to be very cautious about what they see on Google, because not all of those statistics really apply to them.
Exactly. That's exactly right. I'm going to open it up for some questions. I see that we've had a lot of people kind of chime in. So if you give me a second here.
Sure.
I am welcome. I love that people are like, I'm a 1C survivor. I'm here. So someone here says, I learned about ovarian cancer through friends who had family members. I then looked at the resources and found that, okay, American Cancer Society and NOCC. Thinking about the question. Welcome, Swadu from North Dakota, who was diagnosed in 2007. See here, sorry, I thought we had more questions. There's just a lot of like, hi, I'm here.
That's nice.
Thank you. Okay, here's a question from Kathy that says, the Parp inhibitors, how safe are they and how effective?
They are extremely effective and they're also very safe. So any medication that we give has side effects, and there definitely are side effects with the Parp inhibitors, but I think they're very manageable. And with appropriate education, it definitely can be managed. I think the side effects are actually much better than systemic chemotherapy. So they are very effective. They are keeping women cancer-free much longer than ever before. And we're actually even curing some women now who were not cured before. So the data is very powerful, some of the best data that we've actually ever seen in ovarian cancer.
That's fantastic.
It's really fantastic.
Yes, yes. Lori has a question. Is it true that ovarian cancer with ovarian cancer recurrence, that surgery and chemo does not extend lifespan versus just chemo? I'm thinking that you've already answered that, but I'd like you to chime in on that.
So surgery and chemotherapy definitely extends life as opposed to just chemo alone.
Right. Okay.
Absolutely.
This is a little bit maybe a stretch, but what is your opinion on prophylactic mastectomy for those of us that had, this person in particular is stage 4 ovarian cancer and BRCA positive? Should someone go ahead and then do an additional surgery?
So these are very important discussions to have with your oncologist, your G1 oncologist, and your breast surgeon. I think it depends if it's a BRCA1 or a BRCA2 mutation. So a lot of it is a personal decision as well too, given the risks that are of breast cancer with BRCA1 and BRCA2. BRCA1, for example, it's lifetime risk of up to 80%. So I think it's very reasonable to do, and it just depends on which mutation you have and how you feel about prophylactic mastectomy versus screening with mammograms alternating with MRIs every 6 months.
How about any other biomarkers? Are there any other biomarkers that we should be looking at? You talked a little bit about tumor testing, looking for a BRCA mutation there perhaps, or whether a tumor is HRD, anything else that are markers that could be acted on in ovarian cancer treatment?
Really, the best markers are the BRCA status in the germline, what's inherited from your parents. Also BRCA in the tumor itself, that's called a somatic BRCA mutation. And then also this HRD score, very important.
Okay. Are there options out there for people who don't have any of the above?
There are, for sure. So there is one Parp on the market that's FDA approved for women as maintenance therapy, really regardless if any of those things are positive. Also, there's a role for using bevacizumab or Avastin with chemotherapy followed by maintenance. So yes, I mean, unfortunately, women are at high risk for recurrence. And so we do need to employ these maintenance strategies to help really prevent and delay that as much as possible.
For sure, for sure. Shannon asks us, does an IUD with low dose hormones provide the same protection as birth control pills?
So it does for uterine cancer, but not quite the same as a birth control pill for ovarian cancer. So birth control pills, we think the mechanism is it suppresses ovulation, which the IUDs don't necessarily do. They don't do that. So really the best protection for ovarian cancer is the birth control pill rather than an IUD, but that's helpful for ovarian cancer.
Okay, so the pill it is. We have a comment from Lori, and I just want you to touch upon it. We've talked a little bit about BRCA, but she said she was diagnosed with Lynch syndrome following her ovarian cancer diagnosis. And she says that a lot of people really don't know about Lynch syndrome, which raise your risk of ovarian cancer, although most people think of it as colon cancer driver. So maybe can you just talk a little bit about Lynch syndrome?
Thank you so much. That's a fantastic question. So Lynch syndrome is another genetic syndrome. It's a little bit different than hereditary breast and ovarian cancer syndrome, where you have the BRCA mutations. It's actually just as common. And unfortunately, it's not thought of, you're exactly right, or talked about as much. The most common cancers we see in Lynch syndrome, and the prevalence is about 1 in 300 to 1 in 400 women and men, just like with BRCA mutation, so very similar. The most common cancers we see are colon, endometrium, ovarian, and stomach. And so it just highlights the importance that if a woman has ovarian cancer, she needs a full panel for genetic testing. And that's really what the NCCN and the national guidelines recommend, full panel testing, not just testing for BRCA genes or genes associated with Lynch, because we may miss one of these syndromes. One of the best panels on the market, for example, it's 35 genes associated with 8 different cancers, and it includes the genes that are associated with Lynch syndrome, as well as the genes associated with BRCA. And we've been doing panel testing since about 2014. So if you had testing in the past, prior to 2014, and it was negative, you really need an update test. But yes, Lynch syndrome, we do have a lot of prophylactic procedures that are performed to prevent cancers in these women once we know they have Lynch.
One thing we haven't talked upon, and I didn't see it in the chat, but I do want to make sure that we discuss, is that these Lynch syndrome or BRCA mutations can be handed down through the father's side of the family too.
Absolutely.
It's another myth, or something that isn't talked about as often.
Exactly.
Because BRCA stands for breast cancer, people don't necessarily think, oh, I could have gotten this from my father's side of the family.
Exactly. That's exactly right. It can be inherited from either mom or dad's side of the family.
Yes. Heather asks if there's been any improvements in clear cell ovarian cancer.
Well, we're definitely doing more molecular profiling on these tumors. We do know things like bevacizumab, for example, work well in women that have clear cell cancers, and there are, I think the molecular profiling is very important to look for different specific targets and then drugs that might be helpful against that particular target.
So looking beyond it as an ovarian cancer, but what the biomarker is inside the tumor. And
that's correct.
Perhaps maybe a drug that's used in another type of cancer might be effective because of that marker.
That's correct. That's correct.
Lori asks us, has there been any Parp inhibitor made available in a liquid or a dissolvable form? Because I guess one can take pills.
Not to my knowledge. That's a very great question. Not yet. Hopefully one day.
That's right. That's right. I think we have hit on all the questions that have come in so far. So I encourage anyone, if there's additional questions, ask them now while we have our expert, and she can answer your questions out there. So let me give it just another minute here. We're delighted with all the people. I see a lot of names: Lily, Haley, Kim, Rose. Thank you all for tuning in today. This is fantastic. Lauren, Terry, Shannon.
For all of you ladies, I would encourage you to tell 10 of your friends about the things that you learned about today. because we do know in the literature, women don't know the signs and symptoms of ovarian cancer. They're not going to their gynecologist. So if you would, please tell at least 10 of the women in your lives after this call the importance of seeing their gynecologist, knowing their signs and symptoms, if there's any change in their body, getting it checked out right away.
Oh, because I said we were going to wrap it up. I've got lots more questions for you. I think we're okay on time. So if you don't mind, I'm going to ask a couple more. So Kathy says she was 73 when she was diagnosed and there's no family history. So she's assuming that she just got this because of her age, and that's probably the case. It's just a random case and it's unfortunate, correct? You know, if you don't have a family history. Rose is asking, can she ever take hormones? And I'm assuming this means after diagnosis.
So even too, you know, just want to say, even if you have no family history and you do have ovarian cancer, you still need genetic testing. I mean, just having ovarian cancer, even without any family history, you definitely need to have genetic testing. So the data is, the data is a bit weak in terms of hormone replacement therapy for women after the diagnosis of ovarian cancer. That does require a very detailed discussion with you and your GYN oncologist. You know, hormone replacement therapy is for younger women, you know, so anybody after menopause. So perhaps you had a good prognosis, ovarian cancer. I think you just need to have a detailed discussion with your GYN oncologist about that.
I think you already touched on this, but perhaps Gina didn't hear. She said, if your genetic information is more than 15 years old, do you recommend getting updated by your counselor?
Absolutely, yes.
How often do you think someone should be going back?
Just once. She just needs to have a full panel test, and the panels were on the market since 2014, August 2014. So if your testing was before August of 2014, you definitely need an update test. But pretty much anyone who had genetic testing after that point probably had a panel.
One last question, and then I think we'll wrap it up. And this is from Shannon, and it says, can genetic testing results be used against you when trying to acquire disability insurance, life, health insurance, things like that?
That's an excellent question. Thank you for asking that. So if you have a genetic mutation in any gene, you cannot lose your health insurance. There's a congressional act called the GINA Act that protects all patients against losing health insurance for any genetic mutation. So you cannot lose your health insurance. In most states, you can also not lose your life insurance either, or be denied life insurance. So for very young people undergoing genetic testing, you know, sometimes it's best to have life insurance in place. Most of the time, if someone's denied life insurance, it's from a medical, you know, history or predisposition, not a genetic mutation.
Well, I think that we are just about out of time. I want to thank you again, Dr. Lewin, for sharing a lot of information in a very short amount of time.
My pleasure. Thank you.
Second, your recommendation that everyone take this information and share it with 10 friends at a minimum. And because today is our last day of ovarian cancer awareness, it's hard to believe that tomorrow will be October. But thank you to everyone who has been watching and who asked your great questions. So thanks.
Thank you so much.
And happy Ovarian Cancer Awareness Month.